Good morning, ladies and gentlemen. My name is Jay Park. I would like to express my sincere gratitude to the organizing committee for this kind invitation. I'm from Arizona School of Dentistry and Oral Health. I'm so honored to be here, and I also would like to thank you all for being here this morning. Today, my lecture topic is mandibular distalization versus maxillary protraction in class 3 correction with TAS. Today I will deliver part 1, mandibular distalization in class 3 correction with TAS. I received 2023 AAO Jarabag Award during the AAO annual session. Dr. John Callan, left next to me, will be the AAO president after this year's AAO annual session. These are the 2023 CADEVO Case Report Award winners from Japan. If we have a good case, please submit it to the AJODO Clinical Companion. In the far left corner, you can see Dr. Buzz Behrens, the editor-in-chief of AJODO. We appreciate all his hard work and dedication in our specialty. He's here with us today. These are the current ABO directors. I'll be the ABO president after this year's AAO annual session. I have no financial interests or relationships to disclose in this presentation. Today, I will talk about mandibular distalization in class 3 correction with TAS. These are my articles and books I will talk today. What biomechanical considerations do we have to consider during mandibular distalization with TAS? During total arch distalization around central resistance, there is a moment which produced the extrusion of anterior teeth, intrusion of posterior teeth, and tip back of the posterior teeth. In my book, let's take a look at Professor Ch's chapter. During total arch distalization, the incisors are extruded and the molars are intruded due to the moment around central resistance. Or crucially, after extraction of third molars, you can choose location for your mini screws. During distalization with mini screws around central resistance, you can see distolingual rotation of the posterior teeth. Our case was published in the AJODO. He had a class 3 with minus 8.4 millimeters, proclined upper incisors, anterior and posterior crossbite, and midline deviation. How would you treat this case? First, to distalize lower dentition, third molars were extracted. In class 3 patients, if the patient is missing lower 8s, there is a high chance that upper 7s are extruded and interfere with the distalization of lower molars. Therefore, before whole arch distalization of mandible, upper 7s should be evaluated carefully. Usually, total arch distalization of mandible is performed after extraction of the lower 8s. As you know, in class 2 patients, we bond buccal tubes medially on upper 6s to improve class 2 relationship. Likewise, in class 3 patients, if lower teeth are medially rotated, brackets can be bonded slightly medially to correct class 3 relationship. During treatment, to correct dental midline and to distalize lower right segment further, mini screws was relocated from between lower 5 and 6 to between lower 6 and 7, and a sliding jig was applied. This is an illustration of TAD-anchored sliding jig. Total treatment time for this patient was 30 months. To distalize mandibular dentition, TAS can be placed in many sizes, between 5 and 6, between 6 and 7, distal focal to 7, and retromolar area. We have to consider the location of buccal test if distal movement is more than 2.5 millimeters, and if low rate is present, it might be better to extract it during miniscrew placement. Distal movement of posterior teeth using open coil spring and lower power chain and a TAD. Posterior teeth were moved distally to gain a class 1 molar relationship. Then, TAD was located distally to retract anterior teeth. Let's review the first class 3 case. This is after this total mandibular arch distalization. Occlusal views before and after. His low rates were extracted. Class 3 motor occlusion has been corrected. His profile also improved. What about relapse after mandibular distalization? As you see here in Square's study, during distalization of lower molars, tip backs of the lower molars were observed. 1 year post-treatment, relapse in distalized lower molars were 0.53 millimeters at both crown and root to apex levels. After correction of class 3, relapse was noted when molar distalization was accomplished mainly by tipping, lack of functional mastication, and poor retainer wear. After 2-year retention, the midline of the patient was slightly off due to poor retainer wear. After 2-year retention, his profile is still good compared with pre-treatment. According to the lateral saporometric analysis, skeletal class 3 pattern has improved. Upper incisors were slightly proclined due to class 3 elastics at finishing stage. IMPA and soft tissue profile have been improved. As you see here, the lower 6 were tipped back after distalization. Let's see the movie here. After total arch distalization of mandibular dentition, you can see when you distalize, the molars are not body movement. It's more like a tip back. As you see here, lower 6 was tipped back after distalization. I'll talk a little bit about this when I review 3D superimposition. Pre and post volume rendering images. Superimposed volume rendering image. Dr. Tai, my research colleague in Japan, I received the Joseph E. Johnson Award at 2011 table clinic competition. Dr. Tai is here with us today. Our research topic was 3D CBCT superimposition. This is our CBCT superimposition review article. This image shows 3D photo superimposition of over CBCT scans by iterative closest point, which is ICP method. Generally, there are 2 approaches to 3D superimposition: use of the restoration point or a mathematical algorithm. In information theory and mathematical algorithm, there are 2 registration methods: surface-based registration with ICP method and voxel-based registration method. Because our research was more focused on ICP method, in my presentation, I present 3D superimposition technique based on the ICP method. T0 is before treatment, T1 is after expansion with RPE. As you see here, if we use conventional MPR images, before and after reference points may not be identical. Therefore, linear measurements using this reference point may not be accurate. We use 5 different software programs to transform DICOM data into polygon data. These are 5 software programs we used for this study. On the left side, you can see ICP method. Superimposition was performed all areas of cranial base, not the peripheral zone that experienced growth. On the right side, 3D image represent superimposition of T1 on T0 at the cranial base. T0 is pre-treatment, T1 is post-treatment. This is a superimposed image by ICP method. Then the combined image can be cut down at the arbitrary plane in the coronal section. For example, it can be cut down at the first molars. T0 is before and T1 is after treatment. After using ICP superimposition method, the 3D data was converted to 2D data, which we are familiar with, and then specific reference points can be measured. In this article, because of a skeletal crest pattern, after her growth is finished, one jaw, IVRO mandibular setback surgery was performed. 3D virtual images show before and after surgery. In these CBCT images, pre-surgery is shown in red and post-treatment is shown in light blue. In this study, we want to compare the hard and soft changes provided by Swatch appliance in both jaws using 3D superimposition method. Swatch appliance mainly affect dental alveolar complex. In early mixed dentition, using Swatch appliance, the lower crowding was relieved. Before T0, after T1, CBCT images were superimposed by ICP method at the cranial base. This table shows comparison of non-expansion and expansion groups at the first molars. In the expanded group, the values of upper and lower first molars were expanded significantly compared to the control non-expansion group. In this study, we used ICP superimposition method to evaluate dental and skeletal changes in the mandible using CBCT images. You can see the amount of armriding after expansion using CBCT superimposition. Now let's go to our class 3 patient again. MPR images before and after treatment. Left side is 2D superimposition and right side is 3D superimposition. After total arch distalization of the mandibular arch, you can see the occlusal plane rotation, tip back of lower molars, and intrusion of the terminal teeth. So you have to memorize 3 things. How does periodontal change after intrusion of the teeth? There are not many human studies about this question. Although this is an incisor intrusion study, it can also apply for the posterior intrusion. During incisor intrusion, the width of the free and attached gingiva do not reduce significantly. However, adequate plaque control is very important to reduce periodontal problems. Therefore, before considering total arch distalization, we have checked the plaque control status of the terminal teeth. This article was recently published in AJODO Clinical Companion. ADL post-treatment, no significant relapse. Our article was recently published in Angular Orthodontist. What is the difference in the post-treatment stability between total arch mandibular distalization with TAS and mandibular setback surgery? This table shows characteristics of subject in the mandibular arch distalization with TAS and mandibular setback surgery groups. T1 indicates pre-treatment, T2 at post-treatment, T3 at least 1 year post-treatment. The TAD group presented a slightly decreased overjet with forward tipping of incisors and first molars during retention. However, the post-treatment stability of lower dentition was not different between two groups. Therefore, we can consider camouflage treatment in mild to moderate class 3 patients using TAS. I show different cases for TAD placement. You may have a question. Can we place TAD at another side to prevent relocation of TAS during mandibular distalization? In this article, Chris Chang, he will speak on Monday. suggested 12 millimeter length and 2 millimeter diameter mini screws can be placed on the buckle shelves between lower 6 and 7. If we place mini screws on buckle shelves, we don't have to replace them during distalization. In my book, Chris Chang and Jean Roberts mentioned about extraradicular bone screw in their book chapter, buckle shelf test for distalization of lower dentition. Let's take a look at Marshall's chapter in my book. He is here today with us. Class 3 motor occlusion, slightly concave profile, anterior open bite, and midline deviation. How would you treat this case? Power chains were engaged from the long hooks attached to the rectangular arch wire to the buckle shaft mini screws. 350 grams of force were applied on each side. The duration of total distalization of mandibular arch was 7 months. After 17 months of treatment. This is Christopher. He has a skeletal class 3 pattern. You can see posterior crossbite, constricted maxilla, retrocline lower incisors, and midline deviation. How would you treat this case? These are his CBCT images. Pre-treatment radiographs. He shows skeletal class 3 pattern with a hyperdivergent growth pattern. He also had a retrocline lower incisors and retrusive lips. Here the ABO-DI score was 23. If the ABO score is higher than 20, it is a difficult case. Mini screws can be placed on the buckle shelves between lower 6 and 7. Mini screws should be placed parallel to the adjacent root. If the tests are placed on the buckle shelves, we don't have to consider relocation of them. 2 mini screws were placed on the buckle shelves. After 2-year treatment, post-treatment porous and dental cast. Post-treatment radiographs, his SNMP and width have improved. To improve his overjet, lower incisors were proclined and upper incisors were proclined and lower incisors were retroclined. His ABO-CI elevation score was 22. If the score is lower than 27, you can pass the ABO case-based clinical examination. No brackets on lower 4 and 5. If we use buckle sharp mini screws, we don't have to relocate the test. Do we have another approach for distalization of lower dentition? Professor Cook from South Korea is here with us today. We published this article in the AJODO. A Raymer plate can be used for the distalization of lower arch. During flap surgery in retromolar area, L plate is adapted to fit bone surface. Third molars were extracted during surgery. Anterior hole of the plate extends 3 to 6 millimeters lateral to the buccal surface of lower 7. Plate were fixated with 2 mini screws. A power chain can be tied anterior screw hole of the plate. Let's review this case. His chief complaint was, I cannot chew properly. He was 21 years old. His pre-treatment panorex, lower 8 was extracted for mandibular distalization. He shows skeletal class 3 with hypodivergent growth pattern and dental compensation. Graze before and bruise after distalization. To measure distalization, vertical line is drawn at distal contact point of lower 6. After 27 months of treatment. Superimposition of pre and post-treatment. A is intraradicular miniscrew, B is buccal sharp miniscrew, and C is Raymer plate. The errors are comparison of force factor in each device. In Raymond plate application, the distalization force is parallel to the occlusal plane. Our article was published in Orthodontics and Craniofacial Research, OCR. In this finite elemental study, we want to evaluate biomechanical effects of different types of tests in total arch distalization of mandible. Type A is Raymond plate, type B is Swallow plate, type C is buccal sharp miniscrew, and type D is intraradicular miniscrew. Successfully, the Raymond plate demonstrated the greatest distal displacement, followed by Swallow plate, buccal sharp miniscrew, and intraradicular miniscrew. Transversely, Raymond plate was closest to the line of occlusion, which shows the lowest degree of the distal lingual inclination of lower crowns. Vertically, the Raymond plate shows the more extrusive displacement of the molars than other types of tests. Our article was recently published in the AJODO. In this article, we want to investigate treatment effects of the total mandibular distalization with miniscrews versus Raymond plates in class 3 patients. Raymond plate shows more distalization with extrusion of lower molars than buccal miniscrews. Because of the extrusion of the molars and incisors, Raymond plate shows increased clockwise rotation of mandible, but no change in the occlusal plane. Buccal miniscrews produced more intrusion with counterclockwise rotation of the occlusal plane. This information can be used in the treatment planning for patients with class 3 molar occlusion to select proper test type based on their vertical pattern. Because of central resistance of the upper and lower arch, after using miniscrews, you can see the clockwise and counterclockwise rotation of the occlusal planes. We can use box elastics to prevent posterior bite opening. After using palatal plate for upper total distalization, the molars show intrusion and clockwise rotation of upper occlusal plane. After using Raymond plate for total arch distalization of mandible, the molar shows extrusion and clockwise rotation of the mandible. This article was recently published in Seminars in Orthodontics. When Raymond plates are placed on the retromolar area, they can apply force parallel to the line of force. You can see the greater distal displacement of the posterior teeth with Raymond plate than with other miniscrews. As I mentioned before, due to intrusive force factor with miniscrews, it could possibly have been some gingival impingement or lower severs during distalization. So please inform this before you start your treatment. We recently published this article in the AJODO. Measurements of the available retromolar space in the CBCT. A is lingual cortex line, B is buccal lingual width of the distal root of lower 7, C is the posterior anatomical limit, D is available retromolar space. Before total arch distalization of mandibular arch, we can also carry out the volumetric evaluation of the available retromolar region. Both class 1, class 3 groups shows availability at least 10 millimeters retromolar space, 2 millimeters apical to CJ for molar distalization. The available retromolar space was significantly greater in subject with third molars in both class 1 and class 3 groups. Let me show you a case treated by Raymond plate. 27-year-old male patient with cheek complaint of the anterior open bite and underbite. Class 3 molar relationships on the right side. The lower dental midline was shifted to left approximately 5 millimeters. 28 months of treatment. after 35 months of treatment. Post-treatment intraoral porous. Molar distalization was approximately 10 millimeters on the right side, and dental midline was almost on. Pre- and post-treatment lateral septs. However, excessive retraction of lower anterior teeth might increase the risk of gingival recession and descent on the lingual surface of the incisors. You can also see sagittal view of CBCT of the lower incisors. The lower images are the axial sectional views of CBCT of the lower 7, lower right 7. What happened around the mandibular alveolar housing after significant retraction of incisors? The next case will give you an answer to this question. This case was chosen as case months in the AJODO. To treat this case, orthodontic treatment included extraction of lower 4 first premolars, total arch distalization of both arches using a palatal plate. Her chief complaint was lip protrusion. She was missing her lower left 8. She had proclined incisors and protrusive lips. After extraction of her 4 first premolars, 2 mini screws were used for maximum retraction of upper anterior segment. A palatal plate was then used for further distalization. The modified palatal plate includes 2 extended lever arms with 3 notches, 2 posterior holes, and 1 anterior hole. To improve her profile, a palatal plate used for distalization. Along with upper distalization, because if you see carefully here, it's class 1 molar relationship. Class 3 elastics was used to retract lower dentition. If palatal plate fails, we can use lingual arch with 2 palatal tests for distalization. Please take this photo. We can also control the extrusion of upper 6s. Any lab can fabricate this apparatus easily. This is an effective apparatus you can use to distalize upper dentition. I will go back. Total treatment time was 2 years. Pre- and post-treatment panorex. Her proclined incisors and protrusive lips have improved. In the SAP, you can observe dental and soft tissue changes before and after treatment. Saporometric superimposition. Black is pre-treatment, blue is progress after extraction of her 4 first premolars and maximum retraction of anterior segment with 2 posterior mini screws. Red is post-treatment after using palatal plate for further distalization. You can see the significant incisor inclination changes. How they affect alveolar bone responses. We recently published this article in AJODO Clinical Companion. 1 year post-treatment, 3 year post-treatment, 8 year post-treatment. Superimposition of pre- and post-treatment CBCT images showing the amount of incisor retraction. Upper anterior gingival tissue and alveolar bone. Using a small box size on the right side, you can see the better image. You can see bone deposition during the retention period. Lower anterior gingival tissue and alveolar bone. You can also see bone deposition during the retention period. So the take-home message is, if patient has thick and healthy gingival biotype and periodontal ligament, those things are essential for the alveolar bone regeneration. Such third-sectional views of CBCT images of incisors and alveolar bone. You can see better image on the small box size. In this finite elementary study, we reported the biomechanical analysis of the total arch distalization for class 3 correction. At force angulation of minus 23 degrees, the line of force passed through center of resistance. The whole dentition rotates counterclockwise if the force angulation is above center of resistance. If force angulation is below center of resistance, the whole dentition rotates clockwise. This article was recently published in Seminars in Orthodontics. Estimate center of resistance of upper and lower dentition. Required type of tooth movement of upper incisors. In class 2 motor occlusion, intrusive force with controlled tipping, body retraction along the occlusal plane. In class 3 motor occlusion, extrusive decompensation with uncontrolled tipping, body protraction along the occlusal plane. In class 2 hyperdivergent patients, we want to induce counterclockwise of rotation of mandible with intrusive mechanics. In class 3 hypodivergent patients, we want to intrude clockwise rotation of mandible by extrusive mechanics. The steep occlusal plane tends to more curved smile arc and more posterior position of chin point. Conversely, the flat occlusal plane leads to less curved or reverse smile arc and the more forward position of the mandible. You should remember this when you are doing the surgery. 5 steps for the saporometric treatment plan to optimize facial and occlusal traits. Determine the 3D superimposition of upper incisors. Determine the occlusal plane angle. Assess lip competency and chin projection. Determine the oral rotation of the mandible. Determine the position of the lower incisors. In this article, let's review 2 cases. Case number 1. This is not class 3 case, but I want to share with you. Pre-treatment porous and lateral sap. She was 30 years old, and her chief complaints were lip protrusion and chin deficiency. In the ABO scenario-based clinical exam, let's review domain 1, data gathering and diagnosis. This is her problem list. Proclined incisors, edge-to-edge bite, labially displaced upper left 3, crowding in both arches, dental midline deviation, hyperdivergent skeletal class 1 pattern, deficient chin, and protrusive lips. How would you treat this case? In the ABO scenario-based clinical examination, let's review domain 3, treatment implantation and management. Intrusion and retraction with upper and lower 4 mini screws after extraction of upper 4s and lower 5s. Post-treatment porous and lateral sap after 30 months of treatment. Pre- and post-treatment porous and superimposition. After treatment, her profile has improved. Case number 2, pre-treatment porous and radiographs. She was 13 years old, and her chief complaint was underbite and asymmetry. In the ABO scenario-based examination, clinical exam, let's review domain 1, data gathering and diagnosis. Her problem list, chin deviation, straight profile, reverse smile arc, anterior and posterior cross bias, class 3 dental relationship, moderate crowding in both arches, dental midline deviation, transverse discrepancy, skeletal class 3 pattern, and then normal version growth pattern. How would you treat this case? In this case, we used MALP, total distalization of lower dentition with interradicular meniscus and elastics. Post-treatment photos and radiographs after 16 months of treatment. Pre- and post-treatment photos and superimposition. Our article was recently published in Seminars on Orthodontics. Let's review some cases in this article. Case number 1, pre-treatment photos and x-rays. She was 18 years old and her cheek complaint was anesthetic smile. You can notice no upper incisor display while smiling. She also showed lower anterior spacing, edge-to-edge bite, moderate crowding in the upper arch, moderate spacing in the lower arch, procrustation of anterior teeth in both arches. How can you increase our upper incisor display while smiling? This seems like an easy case, but our main focus was how can we increase our upper incisor display while smiling. That's the main focus. Total distalization of lower dentition with TAS around force angulation of minus 30 degrees. You can see the clockwise rotation of mandibular dentition. Post-treatment porous, lateral sap, and superimposition after 9 months of treatment. If conventional mechanics with class 3 elastics had been used, the lower occlusal plane would have been flattened, resulting in the reduction of upper incisor display and worsening smile aesthetics. Case number 2, pre-treatment porous and x-rays. He was 22 and shows skeletal class 3 pattern with anterior cross bite and open bite. He also had dental midline deviation. How would you treat this case? This is a very difficult case if you are not considering surgery. Total distalization of mandibular distalization with TAS between lower 5 and lower 6, or between lower 7 around force angulation of minus 15 degrees, which is above central resistance. You can observe counterclockwise rotation of the lower occlusal plane. Post-treatment porous, lateral sap, and superimposition after 26 months of treatment. Case number 3 is getting harder and harder. Pre-treatment porous and x-rays. She was 15 years old. After cheek complaints, her cheek complaints were chewing difficulties and prominent chin. She shows edge-to-edge bite, mild crowding in the lower arch, mild spacing in the upper arch, retrocline lower incisors, and dental midline deviation, missing upper premolars. She also shows a steep occlusal plane and a prognatic mandible. How would you treat this difficult case? Total distalization of lower dentition with class 3 elastics around the force angulation of 15 degrees. Post-treatment porous, lateral sap, and superimposition after 32 months of treatment. Case number 4, pre-treatment porous and x-rays. It is a transfer case. She was 13 years old. She showed anterior lateral open bites, class 3 motor-occlusion relationship, and increased lower anterior facial height. She also showed a steep occlusal plane. How would you treat this challenging case? Total distalization of lower dentition with upper TAS and class 3 elastics around force angulation of 30 degrees. Progress porous, lateral sap, and supplementary superimposition after 23 months of treatment. Upper TAS and class 3 elastics was used. with forced angulation of 30 degrees. Class 3 and anterior lateral open bites were corrected. The whole lower dentition was distalized and upper molars were not extruded like conventional class 3 elastics. During treatment, condylar growths occurred in the posterior superior direction, which helped to prevent clockwise rotation of the mandible. After 29 months of treatment, her SMI stage was 11, which means that her growth is completed, but we have to monitor her growth during the retention phase. When do we use upper tests rather than lower tests for the distalization of mandibular dentition in class 3 patients? Total distalization of mandibular dentition with upper tests and class 3 elastics around forced angulation of 30 degrees. This technique can be used for class 3 patients with anterior open bites and steep mandibular occlusal planes. Treatment results are correcting anterior open bite, counterclockwise rotation of lower occlusal plane, accomplished treatment without side effects in the upper arch caused by conventional class 3 elastics and backward mandibular movement. This article was published in OCR. What about total visualization of lower dentition in class 2 correction? In this finite elemental study, we demonstrate forced angulation of minus 28 degrees. The line of force passed through central resistance. When the line of force passed through above central resistance, the occlusal plane rotates clockwise. We used 022 slot brackets and 1925 stainless arch wire in this study. During total visualization of lower dentition, backward tipping of the lower 7 due to elastic deformation of the arch wire can be prevented by using a lingually prevent arch wire. In the practical reviews, David Breeze reviewed article and mentioned the direction of class 2 elastics related central resistance. He also stressed the increase of arch wire size in bracket slot to reduce side effects with class 2 elastics. We published this article recently in AJODO. What about total visualization of upper dentition in class 3 correction? At force angulation of 28 degrees, the line of force passed through central resistance of the entire upper dentition. As you know, TPA could be effective in minimizing buccolingual tipping, mesiolingual rotation of molars, and change of occlusal plane, but not effective in anchorage control. This article was recently published in AJODO. What about total distalization of upper dentition in class 2 correction? At a force angulation of 30 degrees, almost bodily distalization of entire upper dentition occurs, but upper incisor shows considerable lingual tipping due to the effect of clearance gap and elastic deformation of arch wire. So to prevent this, we need a torque. Even in force angulation of 30 degrees, the occlusal plane rotates slightly clockwise to the extrusion of upper incisors and intrusion of upper sevens. So from our published articles, when the line of force angulation, line of force passes through the central resistance, force angulation is around plus minus 25 to 30 degrees. Now I will discuss unlighting horizontally impacted lower second molars. Our article was published in the PhD journal. Case number 1, pre-treatment intraporous and X-rays. You can see impacted lower sevens. In growing patient, you should know the posterior alveolar space, PAS, the distance between the intersection of the occlusal plane with the anterior border of ramus and distal contact point of lower 6. In this patient, it has been changed from 6.8 millimeters to 9.5 millimeters. The visual distal width of lower 7, 10.9 millimeters, was wider than PAS. Lower 8 were extracted, and on the right corner, you can see after treatment. Post-treatment intraoral porous and X-rays. Case number 2, 17-year-old adolescent with cheek complaint of impacted lower left 7. The visual distal width of lower 7 was narrower than posterior alveolar space, PAS. You can see PAS changes during treatment. Lower 8 were extracted, and on the right corner, lower right corner, you can see after treatment. This chart shows the PAS changes from 13 to 18 years of age. Compared with this chart, on the average, PAS increased by 1.5 millimeters on each side per year until age 14 for girls and 16 for boys. And also, tweet people also follow this protocol, so you can take a photo of this slide. The biomechanical procedure for unlighting horizontally impacted lower 7 with a retromolar miniscrew. In my book, Chris Chang used the mandibular ramus miniscrews for the correction of impacted lower molars. Mandibular ramus miniscrews for the forced eruption of impacted lower molars. Our article was recently published in AJODO. In this study, we measured the posterior alveolar space, PS, in both arches using CBCT. Using CBCT, maxillary PS and mandibular PS in adults were measured and compared relative to age, sex, and skeletal patterns. PAS, posterior alveolar space, was greater in the maxilla than mandible, and the posterior cortical bone thickness, especially inner cortex, was greater in the mandible. When you are considering total distalization of mandible, please consider this. This is an interesting article I want to share with you. The anatomical limit of the molar distalization in class 2 maxilla was observed at the coronal level, whereas in the mandible, it was observed at the apical level. There is a less potential for molar distalization with hyperdivergent patient, especially in the mandible. So when you're considering distalization of mandible, and if the patient is hyperdivergent, please remember this. Vanessa shows skeletal class 3 pattern with severe dental compensation. In this case, you can observe anterior lingual cortex. If you don't have CBCT, at least after taking X-rays, just palpate with your finger if you are considering distalization of lower dentition. You can observe that anterior lingual cortex is very thin. We have to check anterior bone housing very carefully before distalization. You may know this article. 19-year-old female died during her orthodontic treatment. The patient had a very thin symphysis, and during the 19 months of treatment, the patient's roots were out of the lingual surface of the alveolar bone. You can also see root resorption of the teeth. Now we have CBCT. We see many different things, so we should be really careful. In this study, the posterior anatomic limit of the mandibular distalization appeared to be lingual cortex of the mandibular body. CBCT is needed for patients who require significant mandibular distalization. Dr. Moscovitz invited me to guest editor for the seminars in orthodontics. He passed away recently, and we miss him very much. The title of the issue was Interactions between Orthodontics and Oral and Maxillofacial Surgery. Let's take a look at this article. In my special issue, my colleagues in Korea published this article. The arrow is the lingual cortex of mandibular body. In patient A, after extraction of lower 8, there is a space for lower 7 distalization. However, in patient B, after extraction of lower 8, lower 7 distalization is limited by root contact with lingual cortex of the mandibular body. So if we are considering significance of distalization, please take CBCT and remember this. And this is the posterior limit of the mandibular distalization. Now I will summarize today's lecture. During distalization of the mandible, tip backs of the mandibular molars are observed. During the total distalization of mandible, at the force angulation of 25 degrees, the line of force passes through center of resistance. Class 3 patients with anterior open bite and deep mandibular occlusal plane, steep mandibular occlusal plane can be corrected by total distalization of mandibular dentition with upper TAS and class 3 elastics. So please consider also class upper TAS rather than lower TAS for mandibular distalization. The posterior anatomic limit of the mandibular distalization appears to be lingual cortex of the mandibular body. I would like to express my great appreciation to all those who helped me carry out research. These are my residents and faculty members. I would like to appreciate AJODO and AJODO Clinical Companion editorial team's hard work and contribution to our specialty. Dr. Berge-Barons, Stacy, Alice, Lindsay are here with us today. This is my contact information, jpark@atsu.edu. When you are evaluating my lecture, please be nice to me. If the comment select my lecture, 2025 lecture, after this 2024 AAO annual session, I will continue my lecture in the following areas next year. No, I'm not finished yet. So after my lecture, please take a moment, complete the evaluation. This is QR code. Thank you. I hope to deliver the part 2, maxillary protraction and class 3 correction with TAS. I will show you some slides if I can select it for next year's speaker, because I want to continue my class 3 lecture. We published this article in the AJODO. Group shows anterior and posterior crossbite. She had a full class 3 dental relationship on both sides. After 17 months of treatment, without TAS or orthodontic surgery, you can see the forward movement of upper dentition. She came back to the clinic after 6 years later. My resident, Megan, is here with us today. This case report update was recently published in AJODO Clinical Companion. 6-year retention porous records. Model superimposition showed stable results. I will also cover the mid-palatal suture maturation stages along with MARPI. I will also review all these 3 maxillary protraction appliances. Anterior open bite. This patient shows anterior open bite, class 3 then skeletal pattern, and dental midline deviation. How would you treat this difficult case without surgery? Submental vortex images before and after treatment. After 15 months of treatment without orthodontic surgery. So dear colleagues and friends, thank you so much for your kind attention, and please enjoy the rest of lectures and have a great time in your areas. Thank you so much. Thank you.